Over the past 25 years, we've paid a lot of attention to disease-modifying therapies for multiple sclerosis, and we now have almost 20 different choices. But equally important is symptomatic care for patients with illness. And one of the axioms that we work by is that no matter where someone is in the spectrum of disease of MS, and MS can be very mild to very severe, no matter where they are, there's always something you could do for them. And the idea of symptomatic care, as opposed to disease-modifying therapies, is to make their lives better, to take their individual symptoms and treat them. And so there's things like pain, which can be prominent, neuropathic pain, pain from joints that are not getting enough use and such, so that's an important one that we treat. Spasticity, increased tone, we have medications, we have physical therapy, we have baclofen pumps and things of that sort. Botox, bladder dysfunction is very common in MS, and we have a number of different ways of treating it depending on what the bladder difficulty is. It could be failure to empty, failure to hold, or a combination of both, what's called dyssynergy, but it affects people's lives. Depression is much more common in MS than it is in the general population, and more common than in other chronic diseases, suggesting it's an organic basis for it. Fortunately, the depression of MS tends to respond to the same medications that people who don't have MS but are depressed respond to, and they tend to respond well. Cognitive dysfunction is something we need to deal with, sexual dysfunction. So there's a whole host of things, tremors and such. And the important point is to deal individually with each one, take them apart. Sometimes it means adding on a medication. Sometimes it means taking away medications. And sometimes it means using a medication that could serve multiple purposes. It takes a team of providers, so physicians, nurse practitioners, nurses, social workers, physical therapists, physiatrists, psychiatrists, etc. But it's very much a team because MS can affect any part of the body, because it can affect any part of the central nervous system, and that controls all of your body. And so it has to be managed in multiple different ways. It's not just giving someone medication to treat the MS. You need to treat with the whole person. There are many social issues, which is why we employ social workers. There are nursing issues. There's sometimes a need for injections. So a team care approach is critical. We treat acute exacerbations with high doses of steroids. It's one of the few areas where neurologists are more aggressive than most other areas of medicine. So we use very high doses of steroids. Sometimes they're given intravenously, although some more recent work has suggested you can give very high dose oral steroids as well. Depends on the severity of the exacerbation. The data supporting this are not great, but it's done pretty routinely now to give people either 3 to 5 days of either intravenous or high-dose oral methylprednisolone or the equivalent. Sometimes individuals won't respond well enough, and if they have residual deficits from the exacerbation that are serious, then one can use plasmapheresis, plasma exchange, and that tends to improve recovery in about an additional 40% of individuals.